Welcome to the Innovation Accelerator podcast, brought to you by Innovacer, the data platform that accelerates innovation in healthcare. We're on a mission to connect and curate the world's healthcare information to make it accessible and useful. Accelerate innovation, digital transformation, and your success with population health, customer relationship management, and value-based care with Innovacer. Visit us online at innovacer.com.
Hi, everybody. Welcome back to the Innovation Accelerator podcast. I'm Rich Levin. Today, we're continuing our series on Reinventing the Chief Marketing Officer with our special guest, Timothy Brown, Chief Communications and Marketing Officer for Stony Brook Medicine in Stony Brook, New York. Stony Brook Medicine consists of 4 hospitals and an ambulatory network of 216 facilities, including the university's 6 health science colleges and programs in the New York region. Timothy directs the marketing and communication programs that create a fusion of brand, image, clinical, and research accomplishments. He oversees media relations programs and internal communications for over 14,000 employees. Timothy's professional journey includes a time as a broadcast journalist where he did work for CBS, NBC, ABC, and CNN. Prior to joining Stony Brook Medicine, he held key positions at BioCristie Health and the University of Chicago Medical Center, where he contributed to the success of various high-profile campaigns and initiatives. Known for his strategic mindset and effective leadership, Timothy Brown is dedicated to advancing the mission of Stony Brook Medicine. Through his collaborative approach and commitment to excellence, he continues to make significant contributions to the healthcare communications landscape. Moderating today's show is Gary Druckenmiller Jr., General Manager of CRM at Innovacer. Timothy, welcome to the Innovation Accelerator podcast.
Well, thank you. It's an honor to be here. I appreciate it.
Before we get started, can you tell our listeners a little bit about yourself, what your day-to-day role is at Stony Brook Medicine, what's it like, and what do you and your team focus on every day, and maybe touch on your career journey that brought you to where you are today?
You know, it's interesting. You mentioned a little bit about my background as a broadcast journalist years ago, and it's funny. I got into healthcare marketing when a friend of mine who happened to be a print journalist was leading a system from the marketing communication standpoint and asked me to help him out, and we teamed together and worked in a couple of different places together. And you know, I think really learning how to do kind of the storytelling aspect of marketing. We were talking before we started the program a little bit about brand journalism, which I'm a huge proponent of. To me, that's really what makes the job work. And that's what I try to impart on the team here: content marketing, brand journalism. We don't have a huge budget, but we can really tell our story that way. But yeah, so started out with storytelling. I wish I would have gotten to healthcare earlier than I did, quite frankly. But I've enjoyed every minute of it.
Fantastic, and thanks for that, Timothy. Gary, how about you? Just give us a nutshell about your role at Innovacer.
Yeah, sure. I'm the luckiest person at Innovacer. I get to lead the charge of consumer and patient experience, which is kind of a high level way of saying we're trying to fix the hardest part of healthcare right now, which is the interaction with those to whom we serve. And that's the most important job, and not just in the clinical frame, but their life, right? Like what does a life journey look like? And we're going to get into that for Tim and for Stony Brook, right? Like how do we manifest something like that? That's my role here. And it falls under the construct of the technology CRM, but really it's obviously much, much bigger than that. Here at Innovacer, we're tackling the hardest problems out there, quite frankly. And it all starts with good data, and good subject matter expertise to bring all these worlds that have been siloed for generations together. So real excited to have Tim here today. And we're going to get into some hot and heavy conversation.
Well, how about it, Tim and Gary? That's it for me. I'm going to go hide behind the curtain, and I'll come back at the end of the show.
Terrific. Thank you, Rich. Appreciate it. Well, hey, let's no rest for the weary. We've got a good slot here ahead of us. Tim, again, thank you for joining us. We know your schedule is very, very busy. You've been there, 7 months now?
6 or 7 months.
6, 7 months. Yeah. So you're still digging in, and it's a big organization right in the smack dab in the middle of Suffolk and Nassau County on Long Island. Yeah. But we'd love to kind of hear what your time there has been like so far, and especially as an academic, right? I mean, you've got the school, you've got all the work, you got a bunch of physicians that are, probably at the top of their license, and care managers, and everybody's really trying to do all the great work. In 60 seconds or less, just tell us a little bit about yourself at Stony Brook Medicine, if you don't mind.
Yeah, it's been great so far. I'll just say that the people have been very welcoming, very nice. But it is an academic medical center, as you mentioned, and that makes it kind of a unique animal from a healthcare perspective, I think. But unique in a really good way, because I came from the University of Chicago, which was also an AMC, and there are a lot of parallels between University of Chicago and Stony Brook Medicine, and but in many positive ways. You do have people that are working at the top of their fields, and so you really get that specialized quality care. But where we're kind of unique is we have 216 ambulatory locations scattered all across Long Island, and 4 hospitals scattered across Long Island. And so, the beauty of that is it really allows the patient, our customers, to receive that continuum of care their entire life. I mean, they can have the simple things done, but then if they have something like an AVM or something really complex, they can see our one of our fantastic world-class neurologists. It's pretty gratifying to work there, but there are some challenges. I think AMCs across the country have been a little late to the game when it comes to marketing, and one area that I know is near and dear to your heart is data. And for institutions that are so steeped in data, they haven't done a real great job. And I'm not just saying Stony Brook, I'm saying AMCs in general, of using data in their marketing. And that's got to change.
Yeah. Couldn't be more spot on. There are different factions of the health system universe, as we certainly know. You've got public systems, private systems, mission systems, no money, no mission, right? That's how they go to bed at night. Got AMC's, children's hospitals, but I think you're right. I think there's that AMC and even kind of the children's hospitals are highly specialized. Very acute, a lot of high intensity acute care, episodic care. That's the bellwether of what's made these organizations and the school as infamous as many of these names are. So I totally hear you and agree with you on that one. So I'm going to get this. Your Chief Communication Marketing Officers. That's CCMO. I got that right? Yeah. Okay. I got it. So why don't you give us a little bit of what your CCMO responsibilities are? Because that's actually, that's a trend that I've been seeing. You've had historically, and you know this, you've had the communications officer and you've had the marketing officer, and they do the two generally tend to interact, and they've been two kind of bifurcated universes. Startling that lasted so long. So I'm thrilled that you have both under your watch. Tell us how you see those intersections happening and what some of your responsibilities are at Stony Brook.
I think the connection is hugely important because when you think about communications and marketing, I mean, it's basically there's so much overlap. I mean, if you drew the Venn diagram, there'd be more. It almost looked like a single circle.
Right.
And we've got about 14,000 employees here, roughly. I mean, that's kind of a guesstimate. Those are 14,000 brand ambassadors, 14,000 potential patients, they've got families, they've got neighbors, friends. And think about that. You don't want to leave those folks behind. I mean, not only do you have to communicate to them to get buy-in and further the mission that you're trying to do as an institution, but these are folks that need healthcare too. And if you're not providing healthcare to your own people, it says something right there, and it kind of makes it difficult to sell to folks that are outside of the institution. So I think
you have a small city that you're looking over.
Yeah, absolutely, right. Absolutely. And so I think communications is so critical from advancing the brand message, advancing your strategic plan. You obviously have senior leadership. You need to work and advance their messaging. So it's so critical, and it really does march hand in hand with marketing, because you market internally and externally. I mean, it's really kind of the same thing. You should, I think, be preaching the same message, particularly when it comes to strategic messaging and that brand promise internally and externally. If you don't have internal buy-in, it's not going to work. It just isn't. Externally, you just can't make it work. So yeah, we do both here, and the teams are very, very closely, they're very closely connected. They work back and forth on projects together, and it works quite well.
Good. Yeah, it's as a fellow Long Islander, a former Long Islander, I approve that message, and I'm grateful that you left the Midwest to come back to the East Coast and take on one of arguably outside of Chicago, one of the toughest healthcare markets.
Yep.
is in that tri-state, kind of bleeding up to where I'm at in Connecticut and down into Philly. Man, it's a hot zone.
Oh, it is. Media market of the world. Number one, really. The money that's spent, particularly from our friends in the city, as they push out onto Long Island, because the payer mix is really good out here, is just unbelievable. And yeah, so it's significant. It's a very, very complex, very competitive market.
Yeah. So that's a good segue. So what's the most important thing that you're working on right now, or that you're starting to really kind of drive your attention towards? Is there like one branding, technology?
So both, for us, it's this idea of systemness. And again, I think a lot of AMCs struggle with that a little bit. We've got a very strong, central hospital, the academic medical center that's on campus at Stony Brook. And our job is, and they've been working on this, past couple of years, but it's really ramped up in the past year, is to, become a health system. When we have the 216 ambulatory sites, we have our 2 hospitals out on the Forks, one in the Hamptons and one on the North Fork. The great areas for care, but we really have to. And again, this starts internally. The messaging starts internally, is become that one system. We're not Stony Brook Medicine and Eastern Long Island Hospital or Southampton Hospital. We're just all Stony Brook Medicine. And so, that's critical. So we're working very, very difficult, or very, very, it's a difficult area, but we're working very, very diligently on branding. But technology is a big part of this, Gary, as you well know. And, we've got to figure out a way to work with our patients across their entire span, because that's what we want to be as a system, or a health platform, even taking that one step further from system. We want to care from somebody from birth throughout their entire life, at home, in the hospital, at the ambulatory sites they may be at, and then back at home again, to the very end. And that's what we want to be. That's what when we grow up, we want to do that. We do a lot of that work already, but, and I'm sure we'll talk about that more in the podcast.
It's funny. And when I said before, as a fellow Long Islander, and I just wanted to get that out in the open, because I'm probably going to refer back to that every now and then, but there's a reason for me doing that, because obviously I know the landscape and the geography pretty well. And when you talk like that, and it's kind of how we introed it a little bit too, from our organization's perspective, that hits home in where you're at, probably more so than anywhere in the country, because there's 2 types of people who live in that area. Me, who've left and don't come back. And then those who've never left.
Visit anytime,
I will. My sister's still in Long Beach. I see her all the time. And those who never leave. And there are way more of them, which means you have generations of families that are rooted out in the Forks and the island and in the city. And so what you just stated hits home there, probably more so than anywhere, because now you're talking loyalty of families of generations saying Stony Brook for 10, 20, 30 years, right?
It's funny. I was, this perfect segue to a story. I was out on the South Fork, out in Hamptons area, and talking with some of our folks out at hospital out there. Wonderful facility, wonderful people. And they were telling me, it's like, you're an outsider, and you're always going to be an outsider. So I get that. And they said, because we're outsiders too. And the one woman had actually been born there, but it hadn't been like 3 generations or whatever. And she goes, yep. She goes, you're not really a South Forker or, whatever area we were in at that point.
Hampton.
Yeah. Unless you've been, you've got 3 generations of family back here. So it's a big deal.
It's a big deal.
But these are loyal folks, and they are folks that, they need care. Ultimately, that's the center of it. We want to provide the best care to everybody in at the time they need it and where they need it. And so that's what we've really got to get, through our heads as an AMC, and deliver on that.
So it's a good segue. So let's start at the beginning. We've talked about like life journey and extending the experience as far out to the left and the right as we can, noting that the clinical forbearance is such a narrow window of time. It's the most important period of time, of course, but what happens the 9 months before somebody decides to come to Stony Brook for non-invasive orthopedic shoulder surgery? And then what happens after? What's the 2 years after they've been discharged and they're healthy? Who's talking to them? So let's start at the beginning of that, right? So let's look at consumer acquisition. So consumer acquisition is a pretty hot topic, again, coming out of the pandemic. It was before the pandemic, and now it is for all the wrong reasons, yet again, really important. But organizations overall, and there's no bifurcation between the type. They're all struggling with the mounting costs, low workforce. They want to be able to have like one person do it. They're not going to be able to build out their staffs the way they used to. So what are some of the methods that you're implementing or thinking about implementing to ensure consumer growth is at the top of your marketing game at Stony Brook?
Well, again, I think technology is key here because, what many marketing and communications departments do, and we're guilty of it. Everybody's guilty of it. This isn't a negative view of the people that work there, because it's really, really hard to get out of this mindset of playing whack-a-mole. And so this is where technology and data helps. And it's key. And, we have so many challenges, today with, as you mentioned, a shrinking workforce, shrinking margins. So you really got to get more bang for your buck. But, the key is if you want to bring those patients in and then you never want to let them go. And that doesn't mean you want to do unnecessary treatments or anything like that. Obviously not, but you want to keep them loyal and keep them within your system, your platform. And technology is key to that, and really the patient journey. It's getting more and more challenging for folks, though, across the landscape. With HIPAA compliance and other factors. And I think people are working on that. I know you're working on that. But the key is, and again, I think really to make it a health platform, it's not just the bad times that you want to have these contacts and connections with your patients. It's the good times as well. And preventative medicine is key there. But how can you do that if you're not communicating with them? If you're not talking to them and connecting with them? You can't. And that's where what we've talked about and where technology really makes the difference.
Yeah, and
it's a lot easier to keep a patient than try to bring a new one in the door.
What is it? It costs. Cheaper. Yeah, what is it? It's a parameter that exists across so many different stodgy industries. Let's just call it that it costs probably 2/3 less.
Yeah, absolutely.
I mean, it's like, okay, well then, how does that work? And let's talk about that extension then. So the term journey is now become kind of the operative term. It's a innocuous cliche term that everybody from consumer packaged goods to automotive, everybody kind of uses it. But in those industries, they actually do it. They do it really, really well. I got an old Jeep Wrangler. It's like 10 years old, beat to hell. But I remember when I got it back in like 2013, and I still use this example today. I, clicked on a Jeep ad and I submitted like my interest, and they sent me a few basic questions. And the first one was, when are you looking to buy it? 0 to 3 months, 3 to 6 months, right? We all get that. Like, when are you looking to have your surgery done? And then from there, the journey kind of sets itself based upon time parameters and other things, right? So how do you see that consumer and patient journey evolving, and what are some of the areas that you can see yourself focusing on in that realm when we think specifically about the journey management?
Well, again, it's ease of use, I think, is key, because people want easy. They want quality, and they want it to be easy, and they want it to be cost effective. And that's just basically any kind of dealings you have in life,
sure,
things you buy, whatever. But it's certainly true in healthcare. So, part of that is, one of the things we've done recently is we upgraded our patient portal. It was a big deal for us. Our old patient portal was pretty rough, quite frankly. It was very difficult to navigate. The app was not intuitive at all. The new one is so much better. We just did that. That was big.
Congratulations. It's a big project.
It is a big project, and we branded. That was the crazy thing too. We didn't really have a branded app or portal, so now it actually looks like Stony Brook, which is a big deal, though. I mean,
red everywhere.
Yeah. You can see that red shield right there.
Right.
But again, it's ease of use for consumers. Well, the next step is, how do we communicate with our patients through that portal or other ways? Because you have to meet people where they are. Not everybody reads emails. Not everybody watches, TV or whatever. Everybody has a smartphone almost anymore. So, that's one area that we're using more. With our ambulatory sites scattered around the island, our ease of access is pretty good, but we've got to do better. We have to do better with our scheduling. One of the things that we're working on right now is a call center or a contact center. That's a huge area that we have to improve. Sometimes folks don't want to go to the doctor's office. They may want to just have an appointment on their smartphone or their laptop. That's also an area that we're really working. So some of this is taking cues from other industries. A lot of it is, because a lot of industries, quite frankly, do consumer acquisition and consumer care better than healthcare does. And, I think we're all across the industry trying to catch up in a lot of areas, but, it's, just from a personal standpoint, if it's something that's not life threatening, I'd much rather go sit in front of my computer or pull my phone up and talk to my doctor and get it taken care of than having to get in the car and go into the office. And I think most people are the same way. So we've got to develop that mindset and think that way first. There will always be bricks and mortar, obviously, with healthcare. There has to be, particularly for the really difficult stuff. But again, that's the beauty of an institution like a Stony Brook. As an AMC, we can do the really easy stuff over the phone, or you can go into your doctor's office if you need to. But if you have something really significant that happens that's very, very difficult, we can do that too. We don't have to transfer you someplace else. We'll do it.
Right. Yeah. The nature of, well, congratulations again. And just the portal is driven by, it's probably your EMR, Epic. Is it?
Yeah.
You guys are Epic?
No, we're Cerner, actually.
Oh, you're Cerner. Okay.
Yeah.
Good. Gosh, even better to hear that, you're working closely with the Oracle teams and ensuring that those technologies are being brought to bear. So that's great. That becomes then a spot, centralized place to get X, right? And that's really important as part of that journey, because the journey, as you describe it from the way that it operates in outside industries, those journeys are they're so far advanced. They're malleable at this point. They're ebbing and flowing with every single click, every single call, every single decision you make. And to ensure that it is smooth as silk, right? And that you're not running into any barriers. There's no department to department. You and I met, in Chicago at a conference, and that the nature of that presentation was about departmental silos. When you have departmental silos, that means you have data silos. When you have data silos, it means you have process silos. When you have process silos, it means you have people silos. Down the rabbit hole we go. So, any of us going through that, it's got to be almost, for any health system or health organization in America that is not coming from the retail side and maybe not coming from the payer side, because they've already been through this. It's got to be really hard. And you wonder sometimes, like, how many folks are deciding not to come to one of the larger health systems where they get an AMC mission because of that, right? And that's what we're trying to kind of bring to the surface with this notion of journeys.
Yeah, exactly. Yeah, you don't want to get lost in the shuffle.
Yeah, that's exactly right. So the title of this series, and there'll be several after you, we had Dori Klisas from just down the road from Hackensack Meridian on previously. The role is evolving, and the title of this is called Reinventing the Chief Marketing Officer or Chief Communication Marketing Officer. So it's because it's changed quite a bit since the pandemic. To your point, you've now got Chief Digital Officers as well.
Yeah,
you've got Experience Officers. You got all these people who have now, where they didn't exist before. Prior to the pandemic, there really weren't a lot of CDOs. Now all of a sudden there's CDOs, and what are they doing? So your role has to change as well, not only a harbinger of growth, but also a member of an elite group that has, including those CDOs, including those, executive officers that are looking over experience. And for stuff like value-based care, which is at the opposite end of the value chain, right? So what are some of those areas that you're being asked to delve into differently from the pre-pandemic world?
It's interesting. I think we look at equity in healthcare a lot differently, for one thing, since the pandemic and through the pandemic. So that's a big issue. And with value-based care, again, I think that really kind of dovetails with everything we've been talking about and this health idea of a health system or a health platform, and taking care of people maybe even before they really, really need the high level help and trying to keep costs down, because that's ultimately what it's all about. Care at home, that's an area where we're really doing a lot of exploration, and so they're looking at ways to market that. I mentioned the portal a few minutes ago. Also, virtual care too. That's huge right now. We're looking at ways to really ramp that up. That's one of the, I guess, if there's anything that came out of the pandemic that was positive, virtual care was something that really accelerated. It's funny. I remember I was talking with a physician and I was asking her about that. And I said, do you like it or do you not like it? And she said, I really like it because it kind of, everything's cyclical, I guess. And it's almost like, back in the old days of physicians doing house calls and not showing up with their little black bag anymore, but they're doing it virtually. And her comment to me was, she goes, I can really see the home environment then with the patient and talk to them. And sometimes they share a lot more too, because they're in a, what they
comfortable
consider
space,
comfortable, safe space.
Yeah.
And even visually can kind of see, what's going on in their environment. Maybe even talk to other people in the environment. And I thought that was really interesting. I'd never really considered that before. So, from a marketing standpoint, we're trying to help our providers really ramp up that section of the business, trying to get the word out there. Trying to think what else. And again, I think it really comes back to that whole idea of a health platform, which I do think is the future of healthcare. And I think that's the direction we really need to go, but we have to sell it.
Yeah. Have you started having discussions around open scheduling, having the physicians open up their schedules a little bit?
Well, and that's challenging because we got to.
I had to ask.
Yeah, and that's a very controversial area too with physicians. So that's challenging, but that's one of the areas that we're, because again, that's the age old. Every marketer hears that. Hey, you got to promote me. And then the question back is, well, do you have capacity?
Right.
Well, they can get in 3 months. Well, then I can't promote you because all we're going to have then is angry patients who
right.
That we don't want that. So that's a challenging one, Gary.
Yeah, it is. Well, and again, if it's it's one of those points though, that's in the journey, and self-scheduling, it's coming whether we like it or not. It's just a matter of to what degree and how it gets done. Because I was on a call the other day with a hospital that was talking about how they wanted to get everybody that's coming through their ED tapped into our system so that they could begin to market to them. And they had capacity issues as well. Sometimes for certain service lines, they're maxed out. For other ones, they're under. And so there's this forecasted ability that they're trying to do in order to manage, revenue into the organization and to not to exceed and overburden certain departments while others are just kind of sitting there, I won't say doing nothing, but languishing to a degree. Yeah.
Well, and that's part of the whole crux with marketing, really. If you market service line specific, or if you have to know when to shut it off and when to turn it on. And and you have to be nimble to do that, which most AMCs are not. And we aren't particularly nimble from a marketing standpoint right now. That's an area where we're trying to get a lot better and work on. But, we'll hear from our strategy folks, and we'll say, hey, can you help us here? Ortho, we need some help. Okay. Well, we've got to put together a plan, or can we just turn this on? But we're also a state of New York entity, which makes things a little challenging as well. So we've got to figure out ways to work around that so we can be more nimble with our marketing to benefit the organization and benefit the people that are needing those services. Yeah,
the term is faucet campaigns is one that's been kind of existent for a bunch of years now. You literally, it's there sitting there waiting. And again, like you keep saying, like the health platform or whatever that thing is, it has to have the ability to have them kind of sitting there waiting, ready to go. And you literally just like a faucet, you literally just turn it on and turn it off.
And again, that's where digital, the beauty is right there.
That's the digitization part. Yep.
If you have the data and you know where to turn it on and turn it off.
Exactly. Right. That's the thing. It can't just be a process thing. Yeah. It has to be rooted. Like every single field has to connect to a data point. And that data point has to be accurate so that now, because then you got to get past the fear factor of actually communicating the wrong stuff. I mean, that's, to me, has been the bane of most of those within your role and I know many of them. I've had the luxury of getting to meet many of your peers over the last 10 years, some still kind of stalwarts in this industry. And the one thing I always heard was, gosh, I just don't trust the data. Yeah. I don't trust it. I put out a couple of things and it's supposed to be automated, and it just said something clinically wrong. So to get past that, I think is what also begins to open up much of what you're prescribing. Yeah. How do you see some of these newfound things that we're talking about here, kind of again revolving around the health system technology, and which really is an effort of standardization and consolidation, right? Because also what got us into this pickle was point solution chaos, right? And none of these things talk to each other. How do you see that evolving over the coming years? Like if you had your best choice and you're going to knock out everything you want to do in the next 2 years, how do you see some of these kind of these platforms, as you so eloquently put it, doing their business like maybe 5 years from now? How do you see the impact of those things out that far?
Well, we'd like to be able to we'd like to have the crystal ball to be able to look in the future and see where, we would anticipate growth or where we anticipate a need so we can plan in advance. That's, that would be, we try to do that, but a lot of what we do is reactive.
Yeah. Good point.
And that's always that's not ideal. But what we were just talking about, that's kind of a reactive model, isn't it? When we talk about turning the faucet on or off, we got capacity over here, so turn it on. Well, that's reactive. We should be able to know in advance that we're going to need to turn that faucet on.
Absolutely.
And there are things we can do in advance to prepare for that and be ready for that. So we can trust the data. We can trust our return. And then at the end of that, I can walk into the CFO's office or the CEO's office with a piece of paper and say, hey, look what we did, and here's the return.
Right.
And ultimately, I think that's kind of the biggest thing. If we could be a little bit more proactive in our planning and our work, we try again, but I think healthcare does not do a particularly good job in that area.
Yeah. And again, the answer, as you've stated, and we'll kind of move on to a really cool topic here in a second. Some of the most simplistic aspects of what we find as phase one of being able to do exactly as you just said, having the system do even light prediction, is to connect kind of the tools that fall into our universe, whether it's customer experience on the web on the front end, content management, CRM, and so on. Connect them to 2 or 3 very common legacy hospital or health system-based systems. One is your EMR, which is Cerner, your rev cycle system, and then there's usually like a third that connects into the physician network, so you have that relationship. That's where all of that predictive data lives, and is notably somewhat fluid and exposing capacity issues, the general cycles of referrals, and the general cycles of leakage. And if you're able to harness that, just those 3 data sets, and put them in the hands of folks like yourself, you're predicting now, because now your system, because the systems on our side of the world are smart enough to recognize that information and to be able to identify certain moments in time where there's thresholds. And when thresholds are exceeded or are subservient, the system kicks into high gear and starts, revving up and doing its stuff. Like it's just, and that's not that hard anymore.
Well, and you're right. And what's interesting about that, I was in an executive committee meeting just earlier this week, and we look at some of the dashboards that are being created for ops and for physicians. And I'm looking at some of that and thinking, well, wait a minute. We could use that same data.
Wait, why don't I have that? Right there, why don't I have that?
Yeah, exactly. Right. Where's my dashboard, And so it was funny, we were talking a little bit about that, and I was looking at some of that and thinking, that could be really helpful. We just have to figure out how to model that and use it moving forward, because it's good data.
Yeah. At the end of the day, your job, it kind of comes back to that question of evolution of the role, right? Reinventing the role. Yeah. You are now not only communicator and marketer, you are behavioral ethnographer and data miner. Yeah. Right? Like when you pull those two together, when you just start asking questions around different departments, and like our good buddy Mike Shepard there at Franciscan, he's been at that for a while. He's just been mining all these different departments, but at the same time, he's really tried to understand the ethnography of how decision making is done for healthcare, whether it's self-service or more acute, and those two are very different. So it's that's what the purpose of this is, to kind of expose some of this for folks like yourself and your peers to really try to understand where some of your gold really lives, because it's there. It's there.
The other exciting thing about that, Gary, too, is if we look over at the university side here, Stony Brook, not everybody has this, but as an AMC, we have some great predictive data for folks, geniuses working over there. And, that could be potentially very, very helpful for us. We just have to kind of figure out those ways to work together and harness some of their genius. And I could see them being very, very helpful.
Yeah, lay them off at the school and hire them at the system. I mean,
I don't know
what are we even talking about?
Over in the president's office, I may not suggest that one, but maybe they just want to help their friends across the street.
Exactly, right. We're all one team, right? We're all SBM.
Yeah.
Okay, so let's move off of that. That was great, and I love kind of getting our hands dirty when it comes to these. It's really it's the right brain and left brain, creative world and digital and technical world, trying so hard to come together in our space. And man, we're doing our best, but we've got a ways to go. So in the more traditional marketing sense, your role has been, like it has been for quite a while, manifested heavily on the creative side. Your background is heavily creative, a lot of media, content, design, brand, you name it. Like you're the man, right? And all of your peers come from these backgrounds, and you're now being thrust into these platform-enabled, gosh knows what. So what are some of the examples of how today's CCMOs or CMOs have to become, you already started tipping your hat at this a little bit, your system brand ID, while simultaneously ebbing and flowing your storyline to keep up with what is now an absolutely schizophrenic market. How do you control it? Give us your thoughts on how you tackle brand.
I have no idea, Gary. That's
okay. Let's move on to the next question.
No, that's the $1 million question though. That is tough. And we're, I think we're probably with a lot of folks as to, we're really struggling to find what our brand identity is and along the same lines, what our brand promise is. And it's tough, and we're in the process actually of starting that. Because it's tough because, what are we? We're an AMC. That's great. We have a whole bunch of doctors' offices though. Well, that's pretty good too. We have some community hospitals out east on the Forks. Okay, awesome. We've got a children's hospital. It's really cool. But, so brand identity, brand promise, those are two big areas where, we're struggling a little bit right now. And I think, again, a lot of other folks are, because again, you got to look, I had a boss that told me we can't teach our students. We've got health sciences students here and med students, nursing students. We can't teach them what was done 20 years ago because that doesn't do any good. We need to try to teach them what's going to be done 20 years from now. Now that's hard. But we need to think about the way we provide care and the way we grow as a system or a platform in the same way. And that's pretty difficult. So, that's an area where I think we're looking at it, which is positive, but it's just, it's an area where we struggle a little bit.
You've got brand ID, which is obviously job number one.
Yeah.
But then managing it through a market, then I use the term to define it as schizophrenic. Right? And I still cannot find a better word. You've got Walgreens, CVS, Walmart, grocery stores,
Amazon.
Something else just came out you've got Reinventing. You've got, it's just Rite Aid's declared bankruptcy. I mean, it's like, what's going on? So slaloming the icebergs, like the Exxon Valdez, and trying to avoid the iceberg. How do you control that over the next few years with all of this nuttiness?
Yeah, it's tough. And again, I'll give you another one too. In the Midwest, Quick Trip Corporation is starting to get into healthcare in their gas stations.
Yeah.
You can't make this stuff up.
I know.
And again, what it all comes down to is convenience. That's what people look at. And if you look at brand studies, we just did one recently, and the two top things, convenience and cost, which really was kind of shocking to me because I figured quality would be one of those two, but it's convenience and cost.
So quality has become now the standard. Like that's the expectation then, right? Yep. Like your health system, I have to be cured.
Yeah, no, you're right. You're 100% right. That's the given now. So
right.
You can't.
Right, it's the given.
That also it helps you focus on your marketing, because if that's the given, then the other two are what you really have to push: quality and cost, or convenience and cost.
Yeah.
And so that's what everybody's doing. So we've got to figure out, and we need to do a better job of particularly the convenience factor, because it's kind of what we were talking about earlier in the conversation. People want easy, and they want an ambulatory care setting that's close, so they don't have to drive for an hour to get to it. And on Long Island, it's interesting. It's an island. It's not that huge. It's a big island, but it's not that huge. But it takes a long time, as you well know, to get anywhere on the island because it's a lot of traffic.
495, forget it.
Yeah. So I was talking with some folks out on the Forks, and they were complaining about lack of physicians out there, which is a whole different challenge.
Yeah.
And they were saying, well, I've got to drive to X town to get care, and I'm thinking to myself as I'm looking at the map in my head, well, that's not very far. And they say, well, it takes an hour and a half to get there. And I'm like, oh, an hour and a half to get that 20 miles. That is an issue then, and you don't want to do that. So again, do you provide care in the home? Do you provide care virtually? Do you, and it's probably a combination of all of the above. And this is where, again, traditional healthcare providers have to be careful, because people like Amazon are going to come in and just eat our lunches. It's just, they'll do it.
Yeah. And I'm going to go off script here for a second, just to jump off one thing that you noted in the term convenience, because I love that word. It doesn't get used enough. It's starting to get replaced by other words, and it drives me crazy. Because once, in this industry, it's a huge industry, but man, everybody knows each other on the provider side. So when one person starts to say it, everybody says it. Convenience has typically been articulated on the front end, as in it's convenient to get access into you. Do you think that word is also appropriate on the back end from a prevention standpoint, that you're making it convenient for me not to get ill again based upon the positive, high quality outcome that you've provided me, et cetera, clinical word. So is convenience, is that also convenience through your eyes?
I think so. And that's a great observation, Gary, because again, it gets back to when I was talking about a health platform and talking with a former boss of mine. That was his goal, was to not, you go from being a hospital to a health system and now a health platform. And that platform extends well beyond. That platform extends to wellness. that platform extends to programs in your community to help that are preventative in nature. So yeah, I mean, what's the biggest convenience of all? I don't even have to go to the doctor.
Exactly.
That's way more convenient.
Exactly. Right. Like, once we've taken care of you, we don't want to see you again.
Exactly.
Right.
Well, and that kind of gets back to value-based care too, and some of the basic principles there. But, but again, then you've got a patient for life too. Because you're there for them in the bad times, but if you help them through the good times as well to extend those good times, they're going to be loyal to you, and you've got that patient for life. So, I mean, it's a great question on your part, great observation. And it's really what we have to do. And we have to market that, because it's almost like you're marketing, instead of a product or a place or a thing, you're marketing a lifestyle.
Exactly.
And that's the Stony Brook lifestyle of a healthy life.
Yeah. Yeah, absolutely. Great. Thank you. And thank you for appeasing, because I wanted to, because it's such a great word again, and I've already beaten that to a dead horse, but it doesn't get used enough.
Well, so that's the ultimate convenience.
Yeah. Yeah. Spot on. And again, like you said, quality is now a given. Move on, right? Move to the next sector.
Exactly.
So you mentioned before community, and gosh, if there's nothing short on Long Island, it's the essence of community. I mean, it's the hotbed and the rock of immigration for generations, and families upon families who've gone through this. Take that and apply the notion that healthcare is in fact going local again. So all of your ambulatory centers, you're spreading out east. Great. You're gaining some real market domination in there. We'll get a little bit more of that in a second. The growing competencies of a local health community and health equity. Are there any examples of some of the work that Stony Brook Medicine is doing and that you might have some favor over in relation to those two particular areas, noting that there's a high diversification between the obviously wealthy of Long Island and the not so wealthy?
Well, that's you won't see a bigger, really
swing.
Yeah. Than you will when you go out to the South Fork. So you have the Hamptons, some of the wealthiest zip codes, I think, in the country out there. In fact, I know that. But then you also have a Native American tribe out there, the Shinnecock Indians, and very, very, very active in that area, very active in their communities. We have clinics, actually on the reservation. We have a dental school, which is kind of interesting too. We have dental clinics and health clinics. So that kind of goes back to that connection with the community. And quite frankly, we owe these people. We owe them a lot more than that. Talk about people that have been taken advantage of and had a bad situation, but we don't need to get into all of that, I suppose, right now. But so it's kind of the least we can do. And the physicians that work out there, the PAs, the nurses, the dental, folks, dental students, dentists, it's really wonderful, and they provide quite a service. So, talk about the underserved. That's a community that, they deserve healthcare. They deserve to be cared for, and they deserve to be part of that health platform, as do, quite frankly, the really wealthy folks, in the community of the Hamptons. So it's really quite this interesting, look when you look at that community, because it's such a diverse, group, quite frankly.
And you mentioned it before, the payer mix, although yes, strong, but then you have and I wasn't aware of that. Like, holy cow, Tim, that's amazing. Like that's a great service. Such fascinating. Yeah, that really is. But for them, that's a Medicare, Medicaid, or probably more Medicaid. I got that right. Type of environment. So there now, if we put our marketing and communication hat back on, man, those programs are going to be a lot different for them. Language, phraseology, how they receive it. Some, I would like to think that a mobile phone is everywhere, but probably for some it's not. High-speed internet, maybe not. So that's great. And so with that, because we're now kind of breaking down some of the areas where you're really stretching the moniker of a health system, right? Like that's a great one. And I'm sure you dealt a lot of that when you were at Chicago as well, especially on
Yeah,
the South
we
Side.
were a Southside institution in University of Chicago, and we were in an area of town that was, economically disadvantaged for sure.
Yeah. So this is, within large metro cities, this is going to become more of a thing. So we have to really understand how we separate, one organization from another. And again, it comes down to the same things we've been talking about: better communications, more one-to-one, tying in all the complex aspects of healthcare and just making it really darn easy. Regardless of the general makeup of the tri-state areas, because I keep generally close watch, especially being a Northeaster still myself. Stony Brook is really expanding, not just on Long Island, but in the city too. How do you plan on upping your game and promoting the success of Stony Brook Medicine?
Again, I think we've got to do it in a way that is smarter, because we are up against folks that have way more budget than we do. As we try to expand,
starts with an N, ends with an L.
Yeah, we try to expand across Long Island and even services and partnerships in the metro area, in the city. We can't keep up with the behemoths like Northwell, who are huge. They have a lot of money, and they quite frankly do a really, really good job.
Yeah.
So I'll never be able to, I can walk into the CFO's office and say, hey, you need to quadruple my budget, which probably we still wouldn't touch him. It's not going to happen, obviously. So we've got to think of other ways to really get the messaging out. And, we were talking about brand journalism, content marketing earlier. That's one area that, we do pretty well in, and we're doing better. We're adding to staff there and really kind of up in our game there. And again, it's back to what we talked about earlier, using data, being smart with our spend. And the only way we can really be smart with our spend is through use of data and be very targeted with what we do. So that's what we're going to try to do: a little less whack-a-mole and a little bit more strategic and a little bit more smart, where we put our dollars and our activities. We don't have a huge staff either. We're trying to grow the staff a little bit, but we're dwarfed by the big guys in the city. So we've got to really, really be smart.
It's good to hear you say that. You and I chatted earlier, and I think my term that I typically use it often: whoever ends up with the most data wins.
Yeah.
And that's the smarter way.
Yeah.
Coming over the top has proven to be an antiquated and, dare I say, almost irrelevant, because everybody does it. I'm number one. Nah, I'm number one. No. It's underneath and high, like precision laser caliber type of machines that are kind of coming subterranean is now proving to be what the next 10 years looks like. And many don't doubt that. They just struggle with the cultural change of how to get there. Just while I'm on the topic, what are some of, go ahead, promote yourself. What are some of Stony Brook's highest accolades for our audience to hear?
We've had various awards and things like that. I think we've got some really, really smart people. I mean, we could talk about Health Grades and some of those others, and Becker's, U.S. News and World Report, Newsweek, all that stuff. We've got those, but to me, what we got, for example, one of our neurosurgeons who did just this incredible procedure on a little boy. Those metal straws, those things that have become real popular because people don't want to throw away their plastic straws.
Yep.
Well, there's
I've got
kind
18 of them.
It's dangerous side of it.
They're dangerous? Oh, geez.
It can be very dangerous if you're carrying one and you happen to fall. And that's what happened to this little boy. It actually went in and did some really, really significant damage. And probably by, in most cases, the little boy would have died. But it was such a fantastic story how it was handled. So luckily the kid's father is a physician and clued in pretty quickly that this was more than just like a, broken lip or something, because he was just gushing blood out of his mouth. He actually severed an artery. And they shut down the highway to get this kid to the hospital. They called ahead, and the police actually shut down the highway because it was such a, they knew just seconds mattered, and brought him in. And one of our neurosurgeons saved him. Actually, several of our neurosurgeons saved him and did some very unusual things to do that. And to me, those are the accolades. When you have a team that can do that kind of work that, may not be done anywhere else on the planet, that's really incredible. And those are the incredible stories to tell too, because it's just it's just tremendous. And that's why I love the business, quite frankly. And I was telling you at the start, I wish I would have got 10 years earlier. I really do.
Yeah, I think we all did at the end of the day, especially knowing where we're at now. If we had just a few more years ahead of this, who knows, right? No, I'm with you. What an amazing story. And again, you would expect that from an AMC.
Yeah.
Right. As opposed to others. It is literally a premier platinum class of care, coming directly from the school and those that are coming out of their fellowships. That is truly a separation point. I don't think anybody can doubt it.
It makes it a platform. You can handle the most simple things to the most complex.
Exactly.
And you get it all in the same shop.
Yep. So we're going to start to wind down here. I'm going to bring it back. Thank you for that. That was a great response. So we started at the beginning. We started talking about growth and acquisition. Then we kind of meandered through the journey a little bit. It's like, oh, wow, magically this happened. Now we're going to, and we kind of went to the backside a little bit, and then we kind of came back again. But now we're going to focus on the end of the journey. This somewhat end, right? There really is no end. It's like fashion. It really never ends, right? If you're doing, like we're saying, properly, you do, in fact, embrace a life journey for those to whom you serve within the greater bi-county arena, and perhaps even stretching beyond that as now arguably the top AMC on Long Island, plain bar none, right? So the notion of, and for us, Innovacer here, we play on both sides, right? Because right now that's what we're doing. We have conversations like this with folks like yourself, and we think fee for service and growth and recovery, because we still need to do that, right? But at the same time, our mission is more of, dare I say, VBCRM, which is value-based care, relationship management in some capacity, right? Like we made up that term. I think you would agree a utopian society in that regard is some sort of a 50-50 harmonious balance. So the term pop health, value-based care, and loyalty are not necessarily, however, synonymous with each other. Our population, so here's the big question, and I love throwing this in. Everybody gives a different answer. Are population health and VBC patients considered loyal patients? And then follow up to that is, what does it mean to be loyal to Stony Brook Medicine?
Yeah, it's a tough one. That's an interesting question. So yeah, I think they are considered to be loyal patients. I mean, I do. They should be anyway. And we, our goal is to provide care to anybody who needs it. And when we talk about value-based care, that's always kind of a hot button, but it's ultimately what we need to be doing anyway. It's what we talked about earlier, convenience and cost. It's ultimately what we should be doing. And, we mentioned the Native American tribe a few moments ago, the Shinnecock Indians, and with their very, very wealthy next door neighbors. Don't they both deserve care? I mean, I think they do. And I think they should. I think that's kind of one of the basic tenets in healthcare. And we don't always do a very good job in the American healthcare system that way. It's terrible when you read stories about people that don't get care because they can't afford it, or they get care and they're in such debt that they go bankrupt, or they end up paying off medical bills for the rest of their lives. That's really not a good system.
Yeah, it's not what we got into this for. Absolutely.
Yeah. That's not what it's all about. It's a story I told a minute ago about the little boy with the straw. That's, and he shouldn't have to, his parents have good health care, but what if they didn't? What if they were, his father wasn't a doctor, and they shouldn't have to worry about something like that. They should just have to worry about their child.
Right. Yeah.
I don't know if I answered your question at all, but that's
you did. And and it's a tough one, because these are terms we typically don't like to use in this space.
Yeah.
But we have to start to consider them, because again, especially kind of bringing it all the way back to the beginning, your positions have been in high density, multicultural, high diversification of fiduciary and financial responsibility and income and householding, and just the toughest, arguably you've been in the two toughest markets in America, or at least two of the top five.
Yeah.
So to kind of manage that, we have to start considering the downstream effects, I feel, and I think you do the same, to your point. And there really was no right answer or wrong answer with that, but you stated it like, I've got these high capacity people who's no problem. They'll get the care, they can pay for it. But then on this side, not as easy, but they both deserve the same exact care.
Yeah.
The same exact care. They're going to get the same exact outcome, regardless of how they enter. So does any of that aspect of it, in fact, draw a degree of loyalty? And loyalty comes in many forms. It comes mentally, it comes here, it comes with our wallet. And I think really what we're talking about here is loyalty here and here, right? Like I'm beholden to Stony Brook because of XYZ.
The first health system I worked at, which was a community health system, was an AMC. It was in Kansas via Christie Health. And, we had hospitals across the state, and we were also very connected with some of the small community hospitals in other towns that weren't necessarily ours, but they couldn't make it. And they're closing those all across the country in rural areas. That's an area where people oftentimes forget that there's a real healthcare crisis. It's in the rural areas. At least in the big cities, you may have to drive a little farther, but there's something there. In the rural areas, a lot of them, they don't have anything, because these little hospitals in these small towns they can't make it. So, it gets back to what we were talking about earlier. Everybody, that to me is like an inalienable right. You deserve healthcare. You should be able to get that. And we don't do a great job of it in this country right now. We just don't.
Yeah. And what happens if those rural hospitals shut down? Town shuts down.
Yeah. Oftentimes it's the largest employer in the town.
Yeah, sure is. Okay. Last two questions here. This has been wonderful, as I expected it would be. Hindsight is always 2020 with folks like us. I am, like you, a marketer by trade. Man, we are experts at beating ourselves up in our own creativity at times, taking very risky guesses. It's kind of, well, all right, we'll do that today. Decisions, right? It's because, again, we're trying to draw causality to the creative world and the technical world, and do they generally meet exactly the way we want to? So if you could go back a few years ago, and that would now be, and that could be when you're in Kansas, that could be at Chicago. If there was one thing you would have done differently at any aspect of like maybe during the pandemic, pre-pandemic, however you want to do it, if there's one thing you could do differently, like you said, like I wish I'd gotten to healthcare earlier. If there's one thing you could have done differently a few years ago, what would it have been?
Well, I can't use that answer because you just took it off the table. But
damn.
Stop
talking so much, Gary.
But it's interesting. So I think in the pandemic, during the pandemic, I look at this one because this was, I think for everybody, the pandemic was a huge learning experience, and we, I relied a lot on assumptions, and I think most people did. And I think one of the assumptions is we just figure, people will follow the guidelines and, do the things that physicians tell them to do and accept it, and everybody will be good. Working on the south side of Chicago, University of Chicago, it was very interesting to see that the population there, which is largely African American, there's a distrust of physicians and the medical institution, which a lot of it is deserved, unfortunately. And U Chicago was a kind of a unique thing in the fact that it's a very wealthy institution, but it's in Hyde Park. So it's a wealthy institution in an area that's not very wealthy. And there's a lot of, I think the folks at U Chicago, there was a place, a division called Urban Health Initiative that did a wonderful job within U Chicago Medicine of trying to build the bridges with the community, but it's a tough sell. And we quickly learned that people weren't coming in for vaccinations. They weren't wearing masks. And, our physicians were seeing a lot of people, that were dying, quite frankly, because of it. And so we worked with UHI, Urban Health Initiative, and talked to them to get some ideas on how can we get the word out to the community that they've really got to take this seriously, and there are things that they can do to protect themselves and their loved ones. And that was interesting because that transcends marketing, transcends communications. And again, it gets back to that basic belief that, protecting human life is important. And so we worked with the team, and they had some wonderful ideas, and we really focused on some of our kind of our rock star Black doctors and had them do messaging for those communities. And one area that I thought was brilliant, it wasn't my idea, unfortunately. I wish I could take credit for it. But, a lot of the worship services on the South Side were going online. Church community was huge there, but they were going online to protect people. So we did these little video public service announcements with our Black doctors who were, telling people, hey, you've got to get your vaccination, wear your mask, wash your hands, that sort of thing. Trust us, it's the right thing to do. And so they were playing them before these worship services online, which I thought was really kind of an interesting idea. I would have never thought of that. And it had an impact. I had one of our physicians, wonderful woman, and she sent me an email afterwards, and she said that she had so many people come into the clinic after that saying, hey, I saw you and I've decided, to come and get my shot because I trust you. And so to me, that was kind of cool. But again, that was a mistake that I made because I just assumed, oh yeah, everybody's doing it. But there are certainly segments of the population I don't understand and could never hope to understand. And they have reasons to believe or think the things that they think that, again, I don't get as a, 50-some-year-old white guy. And it's real. It's out there. Yeah, so that was one. So I guess that would be my answer to that, other than trying to get in 10 years early.
That was a way better answer. That's a great story. And man, it just goes to show again, every corner of the country, the interpretation of healthcare meanders just enough to make it different enough to draw pause and ask the question of how am I going to do it here? And it's really a global question, right? Like if somebody has a fever here, we know what the symptom checker is. But if you have a fever in India, the symptom checker is much different. Yeah. Right? Like that's a different type of fever than you're going to have here. So healthcare is not the same for every single population.
Exactly. This one size fits all attitude is dangerous, quite frankly.
Very dangerous.
And that's, but it also shows the value of marketing and communications because, it was through marketing communication efforts to get the word out to the affected community. It's the right message to the right people at the right time and meeting people where they are. And it, undoubtedly saved lives.
Yeah. And that goes back to kind of what we were just alluding to earlier, which you also answered, healthcare going local again. So, communications has to follow, right? So now maybe a future strategy is that all of my the hierarchical structure of my communication starts at the geographical level. Like that's now where I start. I don't start at service line. I don't start at DRG. I don't start at capacity. I start at, block 40326 all the way down to 4093 on the south side, right in Bronzeville and Hyde Park. And they're going to get a very unique.
Showing off your Chicago chops.
I'm trying. I spent a little time there. My mom was actually born in the south side of Chicago back in the 30s. Yeah.
Nice.
But that's an interesting way. I'm not saying it is the way, but it's an interesting way to kind of take that story that you just said so eloquently and really start to reinterpret that to the benefit of a changing degree of cultures, especially in urban centers, but also rural, because the same thing applies there.
Yeah. And here's the beauty of this whole thing, Gary. I think the important thing, and this is where the Amazons, I think, aren't going to quite be able to take over the world because you lose that degree, that home field advantage, I guess.
Home-based advantage, yes.
Yeah, right. And that's where, Stony Brook really has, kind of that advantage on Long Island because we've got the home field advantage. We're not the other guys coming in from the city. We're not, the guys coming in from, a global perspective. We're here and we've been.
Yep, absolutely. All right, last question. If you could snap your fingers and make just one change or improvement in any aspect of healthcare today, what would it be?
I think it's what we just talked about. I think it's access. I think it's affordable access to everyone. I mean, I really do. I mean, I could say other things like, yeah, I want more data for marketing. I want more budget for marketing, which I do. I want all of those things. I want a lot more budget.
Just keep saying it enough and it'll happen.
Yeah. But at a much higher level, it's access, it's affordability. Because I do think, I truly believe this in my heart that every person here in the United States and worldwide, that's one of those inalienable rights, and people deserve to have access to good, high quality healthcare. That's it.
Good. Well, myself and countless other of my peers here at Innovacer could not agree with you more. So convenience and cost. Yeah. That's how we're going to leave it with Tim Brown of Stony Brook Medicine. Tim, thank you so much for being with us. This has been an absolute and utter pleasure. It's great to, I feel like I'm on Long Island when I talk to you, just hearing all the nomenclature brings me back home. So I want to thank you for that as well.
I don't have the accent though.
You will. Give it about a week. Been there a few months. You need just like 2 weeks more and you're almost there. Yeah. Thank you again, sir. It's been a pleasure. Rich, back to you to close us up.
Thank you. I have a Philly accent. We say water for water.
What did you just say? What was
water.
It? Oh
WOODER is water, and gas is GAZ. And just a quick social media tip for our listeners. If you're from Philadelphia, there's a great Facebook group called Meanwhile in Philly that is a lot of fun to be a member of, with all kinds of weird, uniquely Philly things. So I know we're talking New York here and all that, but Philly is like, fine. We always consider ourselves the mini New York. So
the rivalry even happens here on a podcast.
Yes, exactly. I mean, we do have much better soft pretzels. I mean, there's no question about that.
I'll give you that one.
So I'd like to thank you, Tim, for joining us today and taking the time to chat about reinventing the Chief Marketing Officer. For our listeners, don't forget to check the show notes for links to resources and contact information related to today's show. And stay tuned to the Innovation Accelerator podcast for more shows covering the healthcare IT topics that you care about. For more information on enterprise CRM and healthcare marketing and other healthcare IT topics, please visit innovacer.com. That's INNOVACCER.com. I'm Rich Levin, and I hope you have a great rest of your day.
You've been listening to the Innovation Accelerator podcast, brought to you by Innovacer, the data platform that accelerates innovation in healthcare. Don't forget to check the show notes for links to related resources and other information. And stay tuned to the Innovation Accelerator podcast for more programs about the healthcare IT topics you care about. Accelerate innovation, digital transformation, and your success with population health, customer relationship management, and value-based care with Innovacer. For more information, please visit innovacer.com.